Hips have generally have excellent outcomes over the past 40 or 50 years of doing hip arthroplasty. However, there are certain aspects of the procedure that we have not really excelled in, and that's controlling leg length, controlling offset of the hip, as well as cup position. And these are all areas that need improvement to optimize patient outcomes.
I think we could add a couple more things. In the last few years, there's more research coming out that total hip replacement patients have a higher functional outcome if their leg length is restored within a few millimeters, and if their offset of the acetabulum and the femoral head is within like a few millimeters compared to having larger deviations. The sudden we are talking about anatomic hip centers and going away from the conventional positioning of the acetabulum, which is always medializing the cup.
It's still quite amazing to me that most total hip arthroplasties that are performed are pretty much entirely dependent on the skill and the experience of the surgeon performing the operation. There is some crude instrumentation that's used to help align cups, but it's very dependent on patient positioning, and there's really a lot that can go wrong, and that's why we see outliers. So I think what makes this technology special is that it truly is patient specific, therefore it really leaves nobody behind. Nobody becomes an outlier. It gives surgeons the confidence and the tools so they can perform an excellent total hip arthroplasty for everybody.
One huge advantage of this system is that it's not the surgeon who places lately the stem where it belongs. This is 3D planned on a CAT scan. So the size and the positioning of the femoral component is determined by the software and by the CAT scan, by the geometry of the inner femoral canal. So there is a heliotorsion and it changes. Every patient is different. So the hope is that with this more advanced placement of the femoral stem, making it less dependent from the surgeon, that we also can reduce eventually periprosthetic fractures, which is a big problem in uncemented hips, and why some groups recently have pushed like cemented stems again because of the high periprosthetic fracture rate of uncemented stems.
I've been using the Conformis Hip System over the past year, and I've really seen some amazing results with it. The most striking thing is, as I'm an anterior approach surgeon, I use intraoperative fluoroscopy, and one of the biggest struggles for me intraoperatively is really trying to recreate the patient's anatomy, and that's what I see with standard hips. Sometimes I think it's going to be a 135-degree angle, and I get in there, and once I get the hip rotated properly, I realize it's really more of a varus angle, and I need to go change to a different intraoperative plan. Whereas with the Conformis system, since it's all pre-templated using 3D templating based on the CT, what I've seen is intraoperatively I have it's extremely precise, so much so that I've gone right from broaching to right putting in the real stem. And then when I look at my fluoroscopy and compare it, it's like I've completely recreated the patient's native anatomy before it was diseased.
Yeah, I would say my experience was similar. The sudden you realize that everything is like within a millimeter or within a few degrees. So the times are definitely over, and that's where you actually gain very quickly confidence in the 3D planning process of the system, because you know during surgery exactly where you are. It is not that you are flying in big, thick fog trying to land on a landing strip where you really don't know where it is. Everything is clear. You know where your cup is, you know where your stem is, you know how you have to adjust your leg length. It's really tremendous in regards of the accuracy. And this is when I do now a regular hip, which I do less and less, I feel like I'm lost. I don't have that information. So you really rely on that additional information with this system.
It's still, it's still surprising to me that I think a lot of the way that most hips are done in this day and age is the surgeon puts the implants in, the patient goes off to the recovery room, and then they get an x-ray and they kind of see whether they did a good job or a great job or a not so good job. And I think the thing that I've seen over the past year using this technology is, well, number one, when I switched to the anterior approach, one of the things I liked was using the intraoperative fluoroscopy, because it gave me that confidence when I left the OR that things were done right, and I've matched the leg length as best as I could, and I got the cup position as best as I could, but I still didn't have that super level of precision that I've seen with this system, and so much so that now really I think you can eliminate the need for fluoroscopy, which is a big concern of intraoperative radiation exposure for the surgeon over time.
Yeah, I have 2 points in regards to learning curve. Number one, after 5 cases, I was so confident placing the components that I gave up my intraoperative X-ray, and I do a posterior approach. The second thing is that with more and more cases, you're really so reliant on the data you get that you don't want to give that up. So it's just like a very quick adjustment to a new system. Another huge benefit is that the entire jigs are very intuitive. It's not like you have to learn a whole procedure. It's very close to a standard hip replacement. It is just streamlined and cut back on the essential parts that you need. You have one stem, one cup, and you have instruments that give you the instrumentation. So it's very much like a normal total hip replacement, but just much more accurately and simplified.
I think the OR staff really appreciates the Conformis delivery model because they're used to having so many different trays and instruments, and sometimes a lot of the stuff comes out of the sterile processing, and there's contamination, there's holes in the trays. So it's very refreshing to them to see that this system comes in a box, and most of the instruments are single-use sterile disposable, and then there's only 2 trays of reusable instruments that are easy to sterilize and manage.
Yeah, I don't have to add much to that. I had the same experience. Scrub techs, nurses, they all love it. It's much simpler. It's very intuitive, and it's very similar to a standard hip replacement. I think introduction of new technology to your patient actually requires really a high responsibility and a good conversation that gives the patient the confidence that despite this is new technology, that they get something they may actually benefit without being harmed or without being exposed to risk that we experienced in the last year, which was not really there. So the biggest difference of the system is it's basically a CT planned hip replacement. And so we never had that information. So, and I explained that to patients, and the materials are the same. The stem has a same geometry as 20-year results, which are excellent. So I don't think there is really a high risk for a patient to adopt this new technology, but just the fact that the surgeon has much more information to put this device in at the correct position, that I think every patient says, I want it. Why would I want to have a regular hip?
For my patients, I definitely think one of their biggest concerns, and they always ask me, is, hey doc, how are you going to make sure that my legs come out the same length? And I tell them, we do the best we can using preoperative templating, which is done with the X-ray, as well as using intraoperative fluoroscopy, and we do our best to measure. But I think once they hear that they can have a hip that's basically made for them, made according to their anatomy, that matches their anatomy, they instantly take to it. And I share the same concerns about new technology. I think that we're using time-tested materials, time-tested design concepts, and that's removed a lot of those concerns for both me and my patients. So when I indicate someone for a conformis hip, the first step is getting the CAT scan. And then the data using that CAT scan is sent up to the company digitally. And then they use that to create their preoperative model and template where the whole preoperative plan is generated. And that's called the iView. We are alerted when that iView is ready for our review. And then we're able to review all the data in the iView and look at how the implants fit and what the preoperative plan entails. And we can either approve that or we can make amendments to it and then see the revised iView. Once the final plan is then approved, the production starts and then we look forward to the surgical date. The delivery model is such that shortly before the patient's surgical date, the kit will come in a single box, which will be shipped to the hospital or surgery center, and then the surgery is ready to take place.
I think the biggest tip is that you have to rely on your plan. It is really so accurate that you are surprised how much assistance it gives you during the procedure. And you know at every step where you are exactly. So you really have to rely on finish one step after the other, and at the end everything falls into place. You have to be a little bit away from the plan in certain aspects. As a posterior approach guy, I like to work with combined anteversion. So I like a little bit more anteversion on the cup and on the stem as planned. So I plan this preoperatively and put this in the request for the placement of the components. So I think that's a good tip. So still be that way that you are the surgeon, it's not conformis. And the other thing is leg length. Evaluate the patient carefully. Talk to the patient. Do they feel like the leg is long or shorter? Measure it intraoperatively, if you can, or preoperatively, and calculate. Most of the time, the shortening of an arthritic hip is not much more than 3 to 5, maybe 6 millimeters, just in extreme cases more than that. So bring this into surgery and you will see that you are able to reconstruct the leg length much more accurately than you have done before. I think the biggest surprise you will experience with this system is the two-stage reamer system. And what it encounters is that you first ream with a guide, not eccentric, but centric in the acetabulum. And it also gives you the depth to find the anatomic position of the hip center, of the acetabular center, and not the conventional, which gives you more range of motion, less bony impingement, and you will be surprised how easy the system is. And you ask yourself, why have I not been doing this for a long, long time that way? Maybe another tip is, which was a little frightening at the beginning, that you get only one stem and you have to place it. And so doing this for a year, you realize you just have to trust where the stem is planned to go to. So use the jig, the F2, and see if your version is correct. Make sure your box cutter starts really laterally and just rely on it. It does work, and that's, I think, in the beginning I was afraid that that wouldn't work, but it's surprisingly well done.
I think that after using the system for a year, the one thing I've been impressed with is that the system really does work and it's efficient. I think that there have been numerous attempts over the prior years to create a more precise hip replacement. You know, when we look back at navigation, we look at robotics. Unfortunately, I think a lot of these technologies have added time and complexity, and a lot of surgeons don't trust them. Whereas what this system does is it really does inspire confidence, and it's right in your hands in the form of the jigs. So you're getting really amazing feedback that you trust, and I think that's really key. And I think the other thing is, you know, that it's just a well thought out system from start to finish, because you get the plan, you get the tools to execute the plan, and then you get the implant, which actually recreates the patient anatomy. So it's really incredible to be able to offer that to patients.
And the post-op X-ray actually show what was planned prior to surgery.